All right, so good evening. Well, this evening we'll just have an introduction to mechanical ventilation. And as an institute, we are very familiar with this very good saving device. So we'll follow this outline, all right, as on the screen. Then this is just a schematic diagram of a basic schematic diagram of the ventilator, mechanical ventilator. So by way of introduction, one of the main indications for admission to the intensive care unit is ventilatory support. It could be secondary to cardiac arrest or secondary to post-op surgical interventions. It could be for PSO2 control in head injury, whatever it is. One of the main indications for IC admission is ventilatory support. And mechanical ventilation has been defined as any method of breathing in which a machine or a mechanical apparatus is used to augment or to satisfy the entire workflow requirement of a patient's breathing. All right, two things are important here: either to augment, the patient has some ventilatory effort but not adequate, or sometimes to provide the full requirement, the workflow requirement of the patient. So, and a mechanical ventilator may be volume cycled, which means is that cycling from inspiration to expiration may be dependent on the preset volume. It could be pressure cycled. That means it's dependent on pressure, preset pressure, time, or flow cycled. Now, all of the cycling is just a method of changing from inspiration to expiration. So whether you use volume, pressure, time, or flow, these are preset parameters, all right, that controls change from inspiration to expiration. Broadly speaking, mechanical ventilation can be classified into negative pressure ventilation and positive pressure ventilation. We remember negative pressure ventilation during the iron lung of the poliomyelitis pandemic in the early 50s. All right, where people were ventilated in iron lungs. Then we have positive pressure ventilation, which can be divided into invasive and non-invasive. Invasive positive pressure ventilation refers to the delivery of a positive pressure, all right, either via an endotracheal or a tracheostomy tube. Non-invasive ventilation, all right, is the delivery of positive pressure ventilation to a non-invasive interface, which could be a nasal mask, face mask, or nasal plugs. So prongs rather. So each of these has that peculiarity, and the major difference is the invasiveness or otherwise of the provision of positive pressure ventilation. All right, an ideal ventilator should have at least some of the following. All right, it should be versatile. It should be able to provide a tidal volume up to 1.5 liters and a respiratory rate of at least up to 60 seconds per minute. And it should have, facilities for different kinds of ventilatory modes. It should be economical, especially in the resource-controlled environments. You should be able to nebulize medications through it, all right? And you should have monitoring for inspiration and airway pressure, which is important, especially when you want to ensure that you do not cause volume or barotrauma. It should be long lasting. It's not something, it's capital intensive. It's not something you want to be changing every three months. It should have alarm system, which is very important, a safety device, all right, like disconnect alarms, like airway pressure alarms, and all that. And it should be able to clean and sterilize after use. All right, so what are the indications for mechanical ventilation? The primary indication is respiratory failure. All right, when a patient is unable to maintain normal blood gas while breathing oxygen room air, all right, it requires a form of ventilatory support. All right, but before you do that, you need to ensure that the indication for the respiratory support, all right, the underlying condition must be reversible before you initiate mechanical ventilatory support.
In progress.
Otherwise, you may never be able to wean the patient off the ventilator. However, there are some specific indications which I like to call the 4Hs. The hypoxemic respiratory failure. All right, this is due to, for instance, your ARDS, and it's based on your arterial blood gas values of PaO2 less than 60 millimeters of mercury. All right, hypercapnic respiratory failure with a PaCO2 greater than 60 millimeters of mercury. A patient who is hypoventilating with a respiratory rate of less than 5 cycles per minute, or a tidal volume of less than 5 ml per kg, or a patient who is hyperventilated with a respiratory rate above 35 cycles per minute requires some form of ventilatory support or assistance. Okay. All right, so like I mentioned, just for us to remember, we said the primary indication is respiratory failure, and I try to define it here for you. There are two types, and it will be acute or chronic. Now we say that one of the characteristics when we do ventilator is be able to provide different kinds of modes. All right, modes refers to the way the ventilator provides the support. There are two major classifications. We have the controlled ventilation, controlled mechanical ventilation, or the assist mechanical ventilation. All right, assist mechanical ventilation is the most common ventilatory mode employed in the ICU, and it has advantages as it helps. All right, it works with the patient's own respiratory effort. So throughout the support, the patient is participating in the work of breathing. Here, the patient initiates or triggers the ventilator. So the ventilator detects the patient's inspiratory effort and boosts the inspiratory breath to the desired tidal volume or minute volume. Control ventilation, control mechanical ventilation here, you can see on the right side of the screen, the ventilator delivers a preset tidal volume at a specific respiratory rate. This is irrespective of the patient's respiratory effort. All right. And because the patient is not breathing at all during this mode, in between ventilator delivered breaths, the respiratory valve is closed. All right. Peak inspiratory pressure, therefore, develop depends on the patient's lung compliance and airway resistance. If the patient's lungs is not compliant, all right, and you have problems with increased peak inspiratory pressure because the ventilator has been told to deliver a preset tidal volume, and it will go ahead and deliver irrespective of the pressure that it requires. All right, controlled mechanical ventilation sometimes indicated in the ICU in cases of tetanus. All right, especially seizures, some crossed chest injury. Sometimes when the patient is difficult to sedate, a patient is fighting or bucking on the ventilator, as we say it in colloquial language. All right, so these are some of the common conditions where a patient's breathing may be completely taken over by the ventilator. However, we must be aware that it should be for a short duration of time, and it's associated with a lot of disadvantages. Topmost of it is patient ventilator asynchrony. You can have barotrauma due to high airway pressure, hemodynamic compromise for reduced venous return. You can have vacuum mismatch. And this because the patient is not using his respiratory muscle. Patient may become ventilator dependent. All right, so there are different sub-modes under the controlled mechanical ventilation. We have the pressure control ventilation under the control mode ventilation. Here, the ventilator, the driver here is the pressure. So the ventilator delivers a pressure limited time cycle breath. The important thing here is that the inspiratory pressure is preset. All right. It gives, like, if you see the flow here, it gives a decelerating flow pattern. All right. The peak airway pressure or alveolar pressure is controlled because of the preset inspiratory pressure. But the tidal volume, the mean volume, and the alveolar pressure of the patient depends on the non-compliance respiratory rate and the inspiratory expiratory ratio. In this patient, the important thing is the inspiratory pressure is set. All right. And if you look at it here, it's a square wave on the pressure waveform, and on the flow waveform, it gives a decelerating waveform. It has some disadvantages because the inspiration pressure is preset, so you have less likelihood of peak airway pressure, leading to a reduction in chances of barotrauma and hemodynamic disturbances. In this mode, you have better distribution of gases in the alveoli, and there is compensation for loss of ventilation. Sometimes this patient may have reduced tidal volume, all right, if the lung compliance is compromised, or if there's increased airway resistance. This may lead to vacuum mismatch, and eventually you can have patient ventilator asynchrony because the pressure is preserved. Okay. All right, the assist control mode ventilation, all right? Now the waveform is on the right side. You can see the diagram here. In this mode, the ventilator assists the patient's initiated breath, all right? But the important thing is that if this does not happen, if the patient does not trigger the ventilator, it will go ahead and deliver the preset tidal volume. So this will kind of have, you know, a safety caveat here, all right? The ventilator waits for the patients to initiate every breath, and it gets triggered. But in assist control, there's a backup in the sense that if the patient does not trigger the ventilator will go ahead and deliver a preset tidal volume at the preset respiratory rate. Now, on the right side of the slide, you can see the inspiratory pressure, this inspiratory pressure, and once the ventilator detects it, all right, it's triggered and, you know, delivers and assists the patient to deliver. But if, look at here, if there is no inspiratory effort from the patient, the ventilator takes over the ventilatory requirements of the patient. Note that if the respiratory rate is less than the preset rate, the ventilator will assist. All right, if the respiratory rate of the patient is less than the preset, all right? Otherwise, the ventilator will take over the control. The advantages here is that, especially in cases of airway pressure, increased resistance, this mode helps to reduce patient's work of breathing, also works with the patient's breathing, so it enhances better patient ventilator synchrony, produces less vacuum mismatch, and because the patient is taking part in the work of breathing, prevents the disused atrophy of the respiratory muscles. Significant disadvantages include alveolar hyperventilation. Patient is breathing, machine is breathing. So if this is not taken care of, the patient may hyperventilate with breath stocking. All right. There could be intrinsic hydroxic patients who are obstructed, who do not have enough time for expiration. And this can lead to increased mean airway pressure that can lead to hemodynamic compromise. There are different subtypes of assist mechanical ventilation, and we're going to be looking at them as we go on. All right, number one is the intermittent mandatory ventilation. All right, it's represented in the graph on the right side here. In this mode, the ventilator delivers preset number of time-cycled mandatory breaths. And in between that, it stops, allows the patient to breathe spontaneously in between. All right. So this is the patient's breathing. All right. The ventilator breath is the upward stroke and allows intermittently the patient to take some breath. You can see. Well, the problem here is that there could be a lot of breath stacking and it may not be synchronized. You see, this is synchronized here, but there's asynchrony between the patient's breath and the ventilator breath. Here, less sedation is required. You have lesser VQ mismatch, lesser hemodynamic compromise. Like I mentioned, there's breath stacking, and it can lead to increased lung volume and pressure, leading to viral trauma. In order to deal with the problem of intermittent mandatory ventilation, there's what we know as the synchronized intermittent mandatory ventilation, in which case all the patient's initiated breaths are synchronized with the ventilator breath. So the breathing pattern works as a whole, as a unit. This is the spontaneous ventilation of the patient synchronizes with a positive deflection of machine breath, and it works better. But that's what we call the synchronization window, which is the time interval just before the patient triggers the ventilation. It's a time-triggered mode. Breath stacking is avoided here as the mandatory breath are synchronized with the spontaneous breath. In between mandatory breath, the patient is allowed to take some spontaneous breath at any tidal volume that it can generate. All right, a lot of advantages. It helps to maintain respiratory muscle strength throughout, therefore avoid disuse atrophy, reduces VQ match, reduces mean airway pressure, and it's actually those days it was indicated for early weaning of the ventilator. Well, the problem, disadvantage is that if you are overzealous and you want to wean the patient off ventilator too quickly, it can result in high work of breathing, muscle fatigue, and you may go into what we call failure to wean, and the circle continues. Okay, we'll come out to all this later, people and all that. So mandatory minute ventilation, this is similar to intermittent mandatory ventilation, except that it is the minimum minute volume that is set rather than the respiratory rate. Don't forget that the minute ventilation or minute volume is standard volume times respiratory rate. So in this mode, the ventilator measures the minute volume, and if it's less than what the patient requires, the preset mandatory minute, the difference is then delivered by the ventilator as mandatory bed. So the ventilator waits and calculates the minute volume or the minute ventilation of the patient. And if it's less, the difference is provided by the machine, the ventilator. But know that this kind of mode is only suitable for patients with variable respiratory drive. They hyperventilate this moment, they hyperventilate. And when the machine calculates the expected minute volume or minute ventilation, and if it's less, the ventilator provides the difference. PS, the pressure support ventilation is very good. It can be used as initiating mode, or it can also be used as a weaning mode. But know that it supports spontaneous breathing of patients. All right, the ventilator waits for the patient to take his breath, and the ventilator provides a preset level of respiratory pressure. All right, and the idea is to help to overcome the dead space and any form of resistance on the part of the patient's breathing. So the ventilator provides the support that is needed. All right, the pressure is actually applied during the plate two. All right, during spontaneous ventilation. Pre-SV can actually be used in conjunction with any form of spontaneous breathing in any mode. Now, this is SIMV volume control with pressure support. Like I said, pressure support can be used with any kind of ventilatory mode. The idea is whatever tidal breath, whatever inspiratory pressure the patient is getting, there's an additional inspiratory pressure provided during the plate two phase of breathing cycle by the ventilator. So it helps to overcome whatever resistance, and also helps to reduce the patient's work of breathing. Know that this is not suitable for patients with central apnea who cannot initiate spontaneous breath, and high pressure, all right, the requirement for high pressure can lead to hemodynamic compromise. Yeah, there are some other ventilatory modes that are beautiful to work with. The adaptive support ventilation. Right here, at the initiation of ventilation, you enter patient's data, just like the body weight, the percentage minute volume, all right, and you feed this into the ventilator. So the ventilator has a predetermined setting of 100 liters per kg per minute. So it is the ventilator that selects and provides the appropriate frequency, inspiratory time, the IA ratio, and sets high pressure limit for mandatory and spontaneous breath. What you do is that you just enter the patient's data, and the ventilator calculates and provides what is appropriate, in relation to the patient's data that you have entered. All right, this ventilator may be time or patient triggered. Yeah, proportional assisted ventilation, PAV, is a spontaneous breathing mode. And what it means is that it's used in conjunction with patients, spontaneous breathing. It offers assistance to patients in proportion to the patient's effort. All right. If the patient is making good effort, the assistance provided by this mode is lesser. But if the patient is producing less effort, the assistance is greater. So the ventilatory support here is in proportion to the patient's inspiratory or respiratory effort. All right, inspiratory flow, volume, and pressure are variable because the ventilator just waits for the patient and makes enough effort or not and provides it. It is said to overcome 80% of airway elastance and airflow resistance. What it does is that it instantaneously measures flow and volume being put in by the patient, and automatically calculates the compliance and resistance of the respiratory system to now determine how much pressure that the machine must provide to the patient. All right, it's indicated in patients with spontaneous breathing, patients with interrespiratory drive, and patients with interneuromuscular function. Volume assured pressure support is actually a combination of the conventional volume assisted cycles and your, what's it called, the pressure support. So there are two of them. It's one of the dual mode. Volume assured pressure support mode is one of the dual mode ventilatory modes that is available because it incorporates pressure support ventilation and your volume control ventilation. All right. So desired tidal volume and pressure support are preset. Okay. Once the patient triggers the ventilation, the desired pressure support is achieved as soon as possible, and the desired volume is compared with the preset volume. So if the volume delivered is more than the preset volume, the patient goes into spontaneous breathing, supported by the increased pressure delivered by the patient. However, if the volume delivered is less than the preset tidal volume, the ventilator just automatically takes over the breathing, resulting in longer expiratory time until the desired tidal volume is delivered. I love this pressure regulated volume control. I've used it quite a number of times. I've used adaptive support ventilation. I've used this pressure regulated volume control. It's a beautiful mode. All right, what it does is that it's also a dual mode. It's a dual mode ventilatory mode. All right, dual mode is that it combines more than one mode types. The pressure regulated volume control is used to achieve volume support while keeping the peak inspiratory pressure to its lowest level. All right, how does it do that? It's achieved by altering the peak and inspiratory time in response to changing airway or compliance characteristics of the patient. So at constant flow, the peak inspiratory pressure increases with increased flow, increased airway flow resistance. All right, while decreasing flow, with decreasing flow, it decreases flow by detecting reduced airflow resistance. So a lot of times when the flow, all right, is low, it kind of increases the inspiratory pressure and inspiratory time is prolonged. So the idea here is you can ensure that the patient is getting the tidal volume that is required at the lowest peak inspiratory pressure. Yeah, APRV is another dual mode, all right? It's similar to CPAP as patient can breathe similarly. Okay, the airway pressure is maintained at moderately high levels throughout most of the respiratory cycle, but allows for brief periods of, low pressure, all right, so that the lung can deflate or offload. Increased pressure ensures alveolar recruitment and oxygenation, while the period of deflation allows carbon dioxide excretion without alveolar collapse. So it ensures that the airway is kept open. Then during the period of expiration, it's because there's reduction in pressure. So that's what we call airway release pressure. Airway pressure release. There's deflation, which allows carbon dioxide to be offloaded to the atmosphere. It's indicated as an alternative to conventional volume cycle ventilation, especially when reduced lung compliance in ARDS. In fact, ARDS is one of the lung recruitment strategy alongside inverse ratio ventilation. So if you are asked to talk about lung recruitment strategy in ARDS, you must mention inverse ratio ventilation and airway pressure release ventilation, because it's very important in ARDS. All right, inverse ratio ventilation, like I mentioned, all right, earlier on, works hand in hand with APRV because it helps, in patients with ARDS, maximizing oxygenation and also reducing hypercapnia by deflating the lungs for maximum carbon dioxide excretion. One of the problems with R ratio is that if you do, for instance, maybe 2:1, all right, you increase inspiratory time, you are decreasing expiratory time. So you can have carbon dioxide accumulation. But with airway pressure release ventilation, it provides a brief moment of deflation so that your carbon dioxide can be excreted. So this is very important, especially in ARDS patients that they have baby lung or sponge lung. Okay, the problem with this, like I mentioned, I've mentioned some of these things before. All right, tracheal gas insufflation is an adjuvant, not really a mode of ventilation, but just for us to know, this is also an adjuvant and it helps with airway recruitment. Now, the neurally adjusted ventilatory mode, the NAVA mode, it's a dual mode, but it's also more important, because it's different from every other mode, all right? In contrast to other modes, which are just, which adopt the conventional pneumatic signals like flow, volume, and airway, all right, to drive and control ventilation. This one actually detects the electrical activity of the diaphragm through the use of an esophageal tube. So it's a proportional ventilatory mode, and what it does is that it detects electrical activity of the diaphragm, and it offers ventilatory support in relation to the electrical activity of the diaphragm. All right. So it captures the electrical signal for the braccious respiratory center, which activates the diaphragm using a dedicated gastric feeding tube through the esophagus. All right, with this mode of ventilation, the patient retains full control of the breathing pattern. It improves patient ventilatory synchrony, reduces the risk of over-assistance, over-dependence on the ventilator, and it makes it an attractive alternative for patients experiencing clinically significant asynchrony on pressure support ventilation. Now, this is just what I've been talking about. You put a feeding tube or cerebral catheter with electrodes, all right, that connects the diaphragm with the higher center, all right? So the electrical activity of the diaphragm, as provided by the higher center, is sensed and is fed into a vacuum process to the ventilator. The ventilator senses it and determines the amount of support that this patient requires. Okay. Now, so important, we must know how to initiate mechanical ventilation. All right. The machine is as good as operator. So the number one is that you want to ensure, does this patient actually require invasive mechanical ventilation? Some patients can do well with non-invasive. All right. So you must establish that this patient, requires invasive mechanical ventilation. Number two is that you want to ensure that the indication for the ventilatory support is reversible. Otherwise, winning the patient ventilator may become difficult. We have a patient in sick right now, so you can trauma unit that we're having difficulty in winning up the ventilator. As much as possible, you want to obtain consent from relatives or from the patients if conscious. Before you initiate mechanical ventilation at all, you want to obtain your baseline ABG, and like I normally say, 1 to 2 hours after initiation, you must obtain an ABG and compare your baseline what you're doing. Number one, whether your ventilatory settings are adequate and is meeting your target, or whether it's actually also safe for the patient. So number one, you must obtain a baseline ABG and take another ABG 1 to 2 hours after initiation of mechanical ventilation. Before you put the patient on ventilation, make sure that there's adequate supply of gas. In some units, they can't take more than a certain number of patients being connected to the ventilator because of the oxygen supply. When patients are more than what the supply of oxygen can take, the oxygen level drops and you do more harm to patients than good. All right, the next thing is to select the appropriate mode of ventilation. Do you want to assist this patient? And if yes, what type of subtypes of mode do you want to give? Or do you want to paralyze this patient and give this patient full control mode? All right, there's this thing we started, we call it smart ventilation. As time goes on, we look at it. SMART is actually an acronym, which means S for setting, M is for the mode, A is for the adjuvant, R is for release or winning the patient off ventilator, and T, you want to troubleshoot the ventilator in case there's a problem. Okay, so this is smart ventilation. The setting includes selecting the appropriate respiratory rate for the patient's pathology, okay, and for what you want to achieve. For instance, patients with obstructive lung disease should have a rate between 6 to 8 breaths per minute. Patients with restrictive lung disease, you can increase to 12 to 20 breaths per minute. But for patients with normal pathology, 10 to 12 respiratory is okay. All right, and tidal volume. This is the amount of oxygen or gas that is delivered by the patient by breath. All right, and try as much as possible to ensure your tidal volumes are based on mils per kg of their deep body weight. And a deep body weight for a male is 50 plus 2.3 times height in inches minus 60. All right, it's important that you remember that. All right, the ideal body weight of a male is 50 plus 2.3 times height in inches minus 60. So that will give you the ideal body weight. Especially in ARDS, this is important because you want to, in as much as you want to improve oxygenation, the lungs are friable. You don't want to also damage the lung that has been stretched because of consolidation and whatever it is that precipitated the ARDS in the first place. The flow rate, all right, this refers to the speed at which the tidal volume is being delivered to the patient. And you want to set the peak flow rate. Inspiratory time, you want to set, especially for normal patient 1 to 2. For ARDS, you can do inverse ratio ventilation. And, you know, we've done 4 to 1 before, but you have to be careful of the incidence of hypercapnia. FiO2, normally we start with FiO2 of 100, then we come down gradually until we get the optimal FiO2 that will give you your desired PaO2 or SpO2. All right, limit pressure. You want to limit the pressure that the ventilator is given. So for ARDS, for instance, you don't want to go above 30. For other patients, not as 35. All right, because you do not want to cause bowel trauma. But note that in some instances, the ventilator may generate a higher pressure. It may be an indication of an obstructed airway, which may be due to mucus plug, secretions, coughing, and biting on the tube. So this is part of the troubleshooting you will do when you notice your peak inspiratory or airway pressure is higher. You want to troubleshoot why this ventilator, giving high pressure. Trigger and all that, these are things we've done. So the next slide talks about the different modes and how they work. All right, the A is the adjuvants. What do we mean by adjuvants? These are not ventilatory modes per se, but these are modes that can help to improve your ventilatory targets in terms of oxygenation and adequate ventilation. And I normally tell people during my round, I like the word Philippe. So if, for instance, you can come in anyway, I can ask you, how do you improve oxygenation without having to increase FiO2? If our SpO2 is dropping or PaO2 is dropping, we want to increase FiO2. But don't forget that prolonged FiO2 from our last lecture, all right, has a lot of complications known as oxygen toxicity, which I mentioned to you. So in order to improve oxygenation without having to increase the FiO2, you do what we call Philippe. So number one is PEEP. All right. Then you can have CPAP. PEEP and CPAP, the difference is CPAP is for patients who are breathing spontaneously. PEEP can be done for patients who are breathing spontaneously or patients on mechanical ventilation. And I can ask you, enumerate 5 differences between PEEP and CPAP. Okay. Now, high flow, H is high flow ventilation, and there are 3 different types. We have HPPV, which can give you as high as 60 to 110 breaths per minute. And we have the high flow oscillatory ventilation. that can give you up to 600 to 3,000 breaths per minute. All right, the idea is the inverse ratio ventilation, which I've elucidated upon before. All right, inhaled nitric oxide. All right, sometimes we do, individual lung ventilation, especially in patients with pathology of one lung, and you want to isolate that lung to improve oxygenation. All right, prompt partition is indicated when the requirement for PEEP is getting above 7 to 10 centimeters of water. Patients are in respiratory failure, secondary to acute lung injury, maybe smoke inhalation. All right. When there's oxygenation failure, all right, with your PF ratio less than 200, early onset of ARDS less than 48 hours, prompt partition is indicated for this patient. ECMO, all right, is the external artificial circuit which carries venous blood from the patient to a gas exchange device, and the blood is oxygenated and carbon dioxide removed. The oxygenated blood is now returned to the patient, just like your heart-lung machine. And this is reserved for severe ARDS. But note that it is not a definitive treatment. It actually serves to bridge time to recovery, all right, and for the decision to be made on the consequent way forward for the patient. The last one on the smart ventilation technique is the release or the weaning. All right. So, like I mentioned before, you initiate ventilation, you have to ensure that the indication for the ventilation is reversible. So you want to find out, is this patient ready to be weaned? All right. And I like when the patient is no longer a ghost. Okay. G means that GCS has improved. G is at least 13 over 15. Patient is now hemodynamically stable. MAP is above 65 millimeters of mercury and is no longer on inotrope or vasopressor support. Oxygenation has improved. All right, you are having at least SpO2 of greater than 90 at FiO2 of less than 0.5 and with a PEEP less than 10. Spontaneous breathing trial, this patient has passed the spontaneous breathing trial, or the TOPIS index, which is known as rapid shallow breathing index. All right, any rapid shallow breathing index less than 100 per minutes per liter is an indication for weaning. And temperature is now less than 37.5, patient is not spiking. In some cases, you may find it difficult to wean. And when you are struggling to wean a patient off the ventilator, you want to look at the reversible causes of failure to wean, and it's been known as wean snub. All right. Sometimes the patient may be wheezing, so all you need to do is to nebulize this patient. Some patients may be difficult to wean because they have left ventricular hypertrophy or left ventricular heart disease. You want to look at your electrolyte derailment, hypokalemia, hypomagnesemia, and all that. The patient may be anxious. Sometimes I just give them some anxiolytics after weaning them and they settle down. Nutrition insufficiency, it could be over or under nutrition, all right, because appropriate nutrition is important for respiratory muscle integrity. Your patient may have actually developed sepsis secondary to ventilator-associated pneumonia. And I try to wean patients off ventilator after 48 hours, if possible. All right, because after 48, every ventilated day increases the risk of ventilator-associated pneumonia. Be careful of our opioid use, especially as part of our standard sedation. We use morphine or fentanyl. Prolonged use can actually depress respiration, and you may find it difficult to wean your patient off ventilation. Thyroid disease is another common reversible cause of failure to wean. Yeah, so the last is troubleshooting. You want to troubleshoot the ventilator. All right, the first thing, when there's a problem with ventilating a patient, you want to first of all assess the patient's need for audio resuscitation. Is the patient's airway adequate? And then bilateral chest movement. Is the patient's level of oxygenation hemodynamic status adequate? All right, in case of obstruction, you want to look at the airway. Is the tube king displaced, obstructed, or is there a pneumothorax that is developing? All right, that is making the patient hemodynamically unstable, or the tube migrated into the esophagus. So troubleshooting starts with general assessment of the patient. I used to tell people, instead of sending the problem to the monitor, all right, when there's an alarm, don't say, oh, no, this ventilator has started again. That's why it needs to alarm. No, you need to assess the patient and ensure that there is not a patient problem. Many times it may be ventilator problem, machine problem, but the catastrophe is greater if you assume it's a patient is a ventilator or machine problem, and the problem happens to be for the patient. So medical assessment of the patient is crucial in troubleshooting the ventilator. So if the alarm says error pressure alarm, well, you want to look at the process, which could include inappropriate setting of the ventilator. Maybe you set the tidal volume too high, or you set the flow, too high, or the inspection time is too low, or it may also be from displacement of storage tubes. So common causes of increased airway resistance are bronchospasm, reduced chest or lung compliance, and the equivalent presence of pneumothorax. So you just go systematically and look at it. In case of hypotension, patient on ventilator who becomes hypotensive, it could be as a result of hypovolemia, all right, patients behind fluid, or it could be due to drug-induced vasodilatation. And all of these, a rapid bolus infusion of fluid may help to reverse sometimes hypotension may result from a tension pneumothorax. And you need to thank God for POCUS, point of care ultrasound scan. When you see loss of lung sliding, all right, on your lung ultrasound, it points you that to the direction of a tension pneumothorax. And there's nothing you can do except pass a tube. All right, they compress that chest, pass a chest tube, and you see the patient's lung. Sometimes the alarm may be due to patient ventilator asynchrony. All right, you need to find out why. All right, is this patient breathing out or synchrony with the patient? All right, a spontaneous breathing patient on controlled ventilation will breathe against the ventilator, so maybe the patient is not appropriately sedated. And sometimes, if you have difficulty in sedating a patient to sync with the ventilator, in rare occasions, you may need to paralyze the patient. Patient desaturating, what happens? You want to do a quick bedside ultrasound to rule out pneumothorax and other causes of desaturation. All right, you want to quickly. I can't forget this. A patient who was being managed in the ICU during nursing care. Accidentally, the tube came out, and instead of the attendant nurses to allow the doctor, she just pushed the tube back, and obviously the tube went to the esophagus, and patient desaturated very quickly. So if patient can't desaturate the ventilator, you need to go stepwise to troubleshoot and find out why is this patient desaturated despite this. All right, but importantly, you want to increase the FRO to 200 momentarily. You want to auscultate the chest and to check out for equal bilateral chest sounds and discussion. All right, there could be leak around the cuff of the ET tube or even the tracheostomy tube, and this will produce an abnormal sound around the trachea during inspiration. There could be circuit leak also, along the connection. All right, leak checks are typically performed when the equipment is prepared for use. All right, it is not when you started that you start tracking for what's it called, leak test. All right, so but when you detect a leak test, find out what the problem is and change it. All right, so this is a sketch, all right, of how to troubleshoot the ventilator. Complications could be respiratory, gastrointestinal, and others. It could also come from equipment failure. So respiratory more, you can have barotrauma, pulmonary edema, tension pneumothorax, VQ mismatch, surgical emphysema, atelectasis, trachea damage, hyperventilation may occur. Pulmonary oxygen toxicity from prolonged use of high FiO2. You could have the ventilator pneumonia, which could result from upper or lower airway infection. All right. GIT complications, you could have pulmonary aspiration, stress ulcers. All right. Mechanical ventilation is an independent risk factor of stress ulcer in ICU. Gastric distension, paralytic ileus, and malnutrition, which can also eventually lead to failure to wean. Others, nosocomial infection, all right, and fluid and electrolyte imbalance. You can have accidental disconnection. That was a reporter who disconnected a ventilator from the light source because he wanted to charge his phone. All right, this is accidental disconnection that can be hazardous to the patient. Yeah, ventilator-associated pneumonia, you know, we have a bundle for it. There are actually about 6 bundles, infection control bundles in ICU. And ventilator-associated pneumonia bundle is one of them. And this is the bundle: head of bed elevation, spontaneous awakening triad, and spontaneous breathing triad. You want to do subglottic secretion drainage plus tube cuff pressure to ensure that it's more than 20 centimeters of water. 10 ventilator tubing and social system only when clinically indicated. Now, these are the ventilators with the pneumonia bundle. All right, so we've talked about oxygen. I think we'll stop here today, and we will go to winning modes next time, and we'll talk about ventilating requirements of some specific clinical conditions like ARDS. What are the specific ventilation protocol for COPD, for asthma, for traumatic brain injury, and then we can talk about non-invasive ventilation. So thank you so much. I think we'll stop here today.